Hannah, and this is going to be like the speed dating over lunch with 30 minutes. So people say I talk fast already, so buckle up. Here we go, because I want to leave time for questions. So key takeaways, I will let you read that at your leisure. The presentation will be sent afterwards, so you can revisit that, but we're going to cover all these points and many more in the next 30 minutes. So first I wanted to talk about and set the stage for how drug pricing should work. And it's something we at CapRx like to call the Tylenol rule. And essentially what this means is when anybody goes into the pharmacy and they buy something for a headache, and it could be a Tylenol, Advil, it could be generic of both those versions, you know exactly what the price is of all those different options. You're able to pick the one you want, go to the register, pay pretty close to what you said after taxes and all that other fun stuff, and then you leave and you know exactly what you paid and what you're getting. However, you walk a few feet back to the pharmacy, you spin the roulette wheel as a member, and each and every month your price changes. And it really doesn't have to be that way. And why is it that way? And when we start to talk about these 5 key components of an optimal PBM deal, you'll start to discover that this is really the only place in our consumer ecosystem where we have come to accept the fact that drug pricing isn't known, no one has any idea what they're going to pay, and for some reason, that's okay. So we're going to talk about why it's not okay and what you can do in your contract with strategies to prevent it happening moving forward. So I want to take a little step back. I'm not going to go into each of these buckets because I've looked at the attendee list, and I know many of you, including my competitors on the call, know exactly how PBMs make money. And one of the main focuses is to look at these and to understand how they tie into these 5 optimal strategies. So for admin fee, in the case of admin fee, again, this is something that's kind of gone away of the dodo. And the reason being is that employers love this concept of zero admin fee. Doesn't exist because trust me, you're paying. But again, that's one source of revenue for PBMs. Retail network, this is where we're seeing lots of movement at the state level on fully insured business, and already exists in Medicare, where the PBMs can make money on spread. And what spread means is they pay the pharmacy one thing, they charge the client another, and they keep that difference. Mail order and specialty, I think a lot of people scratch their head, well, wait a minute, how is this revenue? Well, it's revenue because now you have the largest entities in the country owning the assets that are dispensing. And remember, mail/home delivery specialty combined is almost 50% of all scripts being dispensed at this point. So it's a very relevant component of how a PBM who owns these assets can make significant margin off their clients. And then the old tried and true, which PBMs have been taking advantage of for many, many years, is pharma revenue. We say that instead of rebates. You can see the various buckets here that exist. Way too short of a call to dig into all those, but there's many components that make up what's called pharmaceutical manufacturer revenue for client option. So role of the PBM, the supply chain. One thing I really want to make clear, which I think is sometimes lost in our discussion of traditional PBM models versus pass-through transparent acquisition model, is that PBMs are necessary. They provide safety edits, they coordinate care, they're able to make sure that folks on the opioid side are not double dipping at multiple pharmacies. That's a major role that the PBMs play to support Medicare and also commercial clients in that space. So there is a role for PBMs. The fact that the question is, how deeply do they need to be involved in this montage of services? Should they be owning assets? Should they be owning aggregators? You know, what are the true components of what a PBM should and should not be doing, so that their interests are aligned, not just with you as an employer, but also for your members in terms of out-of-pocket costs. So I want to educate on another acronym. I know it's like PBM, of course, is an acronym in of itself, and now we have another acronym. But this one is not new. It's been around for quite some time. National Average Drug Acquisition Cost, or NADAC, or if you're from Chicago, NADAC. And what we want to talk about this metric in terms of as an alternative to wholesale acquisition costs and AWP, and average wholesale price, if you will. And those two metrics, WAC and AWP, are published by a third party. They're gathered from pharmaceutical manufacturers. And in general, we all joke, everybody on this call, from consultant to my competitors to employers, joke about the fact that it is not what drugs cost. And so I think everyone can agree that AWP is not the actual acquisition cost of a drug or any reflection thereof. But yet we use it for 99% of the pricing mechanisms in the US. So you can see where I'm headed with probably number one strategy in your optimal deal. Look at something else. What I'm suggesting here is what we call NADAC, National Average Drug Acquisition Cost. It is not perfect, but none of the metrics are perfect out there. But National Average Drug Acquisition Cost actually brings in retail pharmacy survey data on what the actual drugs cost for them to acquire at retail. People get all wrapped around the axle, oh, it's only 20% of pharmacies, and how can that be accurate? My question back is, it isn't perfect, but 0% of pharmacies report AWP. So tell me how that should be our industry standard. So again, I want to make sure you take away from this that this isn't about that NADAC is the be all end all, but it certainly is better than the standard we're using everywhere in the market today. Single ledger, what this essentially means is that you as a PBM want to have one set of books, not a set for the clients and then a separate set for how you deal with retail, your mail service provider, and your pharma revenue. And in this case, it's just to illustrate that having the understanding that a PBM partner, when you select them, has a single ledger system at any point in time, they can show you where their profits are being made is key in terms of being a truly transparent organization. We're going to talk a little bit later about the Consolidated Appropriations Act and some recent reporting that employers should have had their hands on. However, I'd be willing to bet most employers did not either see it or review it. And I'm going to say why it's important to start looking at that information, because a lot of this information about where your PBM may be making revenue that you're not exactly familiar with is right in front of you. You just have to take the time to look at it. So as I mentioned, NADAC over AWP, one of the main reasons is because, as I said, it's reflective of retail acquisition costs. You ask any retailer out there, especially an independent, because the big guys at the local retailer aren't going to know how drugs are purchased within their massive chain, but a regional chain or independent, they will tell you that generics get cheaper each year for them to purchase from an acquisition standpoint. However, all of our contracts say it actually goes up. Well, impossible. Generics get cheaper over time. You can see the blue line on this slide shows that the actual acquisition cost coming from retailers has dropped 64% from 2015 to 21. But you can see AWP goes up a half a point to a point every year. So what does that mean? That means when your PBM in the second and third year of your new agreement gives you a point or half a point better, and you're like, oh, I'm getting a better deal. You're not, because the trending on AWP is going in a perverse direction and isn't at all related to how drugs are actually trending in the marketplace. The next question I always get asked, what about brands? So people always ask, well, that's generics, that's a small part, let's talk about brands. This year, for the first time, you look at brands and specialty, there was a pretty significant decline in acquisition cost around that. And again, we're still digging into exactly what the data is showing. Specialty, the mix is a little quirky because you're dealing with, a smaller basket of drugs, because so many of those are done via home delivery, and home delivery does not report to NADAC. So it's just an interesting phenomenon that brands tracked pretty closely in terms of their AWP and NADAC, where we're starting to see a divergence. And we're just beginning to understand why that is, and if that trend will continue forward like we've seen with generics. So what are the 5 recommendations? It only took me to slide 12 to actually cover what we're talking about. So anyway, be patient with me. So as we look at this, number 1, I've hit pretty hard. Replace AWP and MAC with a rational pricing methodology. 2, identifying PBMs that do not own conflicted assets. 3, identified PBMs that do not retain pharma revenue, meaning they're going to pass through 100% of that value to you as a client. 4, negotiate claim level commitment pricing for all drugs. And what I mean by that is, if you look at your contract today, this is the way it works. It says across all brand drugs over a year, you're going to pay an average of this. Who buys anything like that? Do I go to the gas station and hope I pay $5 a gallon on average? One day I may pay 10, the next day I may pay 2. That is not the way life works. But we've accepted it in the drug industry and how we price deals that, drugs really don't have a price. So it's all drugs and average over a year. It makes no sense. So there is a way to price drugs at the drug level, and that again is using a different indices like NADAC, where drugs actually have a price versus AWP. We'll go to the next one here. Sorry guys, it's sticking on me. There we go. So digging into replacing AWP and MAC lists. So I've already kind of beaten these up quite a bit, but Again, as you can see with AWP, again, it's more of an arbitrary price metric. Everyone in the industry jokes about it means ain't what's paid. So it's time we stop joking about it and we do something about it, right? So I think I've been saying that for 10 years at least. And what AWP allows a PBM to do is to create what's called a MAC list, or maximum allowable cost list. I guarantee you there's a bunch of people on this call that don't even know where that term comes from. It actually came from the government. It used to be called HIPAA MAC or Medicare MAC. There were all these generics. The government was like, we can't manage all these prices. Here's the price we're going to pay. So PBMs leverage that, use the ambiguity of AWP, and create this very big universe of multiple lists, multiple pharmacies. Bottom line is, it results in your members never knowing what they're going to pay for a drug at any given moment at any given pharmacy. And that is not acceptable. So where did the prices go? That's really the question here. It's kind of like a Where's Waldo on medication, right? You look at the pharmaceutical manufacturer, they have a price that goes to the wholesaler. The wholesaler sells to the pharmacy. There's a price. That's the NADAC essentially. And then pharmacy sells to a plan sponsor. We don't know, because I said, you look at your contract, it's all drugs over a year as an average. Again, so it really breaks the clarity in the supply chain when it gets to you as a plan sponsor, and it doesn't need to be that way. So there's all these people that make up reasons why this can't be done, and it's just a way to confuse and create opacity, which allows PBMs to take advantage of the plan sponsor and the ultimate payer and member in this case. So what do we replace it with, and why do you want to do it? Again, Medicaid has already figured out that NADAC is what they want to use and how they want to manage it. And they have acquisition costs in about 47 fee-for-service states. It's very well established in that case, but you can see there again, there's no need for definitions of drugs. You can't manipulate it. It's literally reported by pharmacies in terms of how they utilize it. Oops, no, I'm not going forward here. Let me see. There we go. So number 2. Identify PBMs that don't use owned assets to make spread. So most PBMs own mail and specialty pharmacies. And not that that is a terrible thing, but when it's now 50% of our dispensing in the US, you have a lot of your spend routing through an asset where the fox is watching the hen coop, right? So if profit and earnings are derived from mail and specialty dispensing, where is the incentive for a PBM to manage what is going out of those assets? And where is the incentive to make sure that you as a payer, if retail might be cheaper in some cases, but they're telling you, nope, everything has to go to this one channel. And a lot of your deals out there are contingent upon using exclusively a certain mail and specialty provider, which is usually an owned asset. In fact, I would encourage everyone to just do a little test and say, what happens to my pricing if I carve out specialty to a different provider? You will see your pricing go upside down, and that'll tell you immediately where the money is going. Again, this is along the same lines, is that, find a PBM who is literally willing to work with anyone that's licensed and accredited. Very important comment. We have a lot of new startup mail and specialty providers out there, and you got to do your due diligence, because some are in and some are out, and you got to make sure they have their credentialed, they have their licenses, that they have their UR if they need it with certain states. These are all very important things. People get excited because of a digital strategy, or they're able to do something faster, unique, or they can put it into a little pack, and then you find out they're not licensed in all 50 states for non-resident. So there's a whole bunch of details around that, but there are lots of great partners out there that a PBM can contract with. Or here's an idea: let their client decide who they want to use. Present the options and let them make a consumer decision that they believe that this pricing and service model from a non-owned PBM asset would service their members well. What's great about that is it disconnects the clinical decision-making. So when you are an owned specialty pharmacy of a PBM, if they own you, the clinical criteria is coming out of the PBM, which causes the drugs to be approved and go out the door. When you don't own that asset, the criteria is owned by a third party, meaning the PBM that doesn't own the specialty asset. And they're able to create criteria that is conflict-free of what is being dispensed out of the facility. And that is a very important point. Identify PBMs that do not retain pharma revenue. So we finally got rid of Duexis on here, but the generic is still around and it's still $400. Insane. Still showing up on claims. I would be a millionaire by now if I had $1 for every time a client, like most of you on the phone, told me we don't cover those, and I get your claims data and it's on there. And I know the consultants excuse me, on this call know that as well. So you may believe you're not paying for these, but again, I don't think I've seen a claim file where it's not on there. Livalo is another one that's being used. It's another statin. Trust me, generic Lipitor and Zocor work just fine, generic Crestor, but now there's another one in there. We're covered and seeing it on formulary, very costly, but you can see huge rebates. So that's a great thing for the PBM, not a great thing for you when you could have a pennies on the dollar for Lipitor, which is really tried and true in that space. So I kind of alluded to this earlier on, that pharma revenue is more than just rebates. There's clinical fees, there are inflation protection penalties. You want to make sure you define in your contract that any dollar, no matter what you call it, that comes from a drug manufacturer to your PBM that's related to your utilization comes back to you as a plan. It's very important because it helps align decision-making and allows you to get the most value for your benefit. Or negotiate claim level pricing commitments. Again, this is where I said, why do we live in a world where there's this rolling average of what a drug costs? And then there's definitions and exclusions. All that goes away when you're willing to say every drug has a price. And we use a third party called NADAC, which by the way, is free. It's publicly available. You as a client could actually go and look at it any day of the week and see if your claims are actually paying at that. If you're using NADAC, you can't do that today with AWP. You got to hire an auditor. They have to timestamp the things. They have to get the AWP reference price. When the PBM updated, it's a convoluted mess. NADAC actually helps you remove that opacity in that audit process and allows you to look at claim level pricing, which is unique, but shouldn't be to the pharmacy space. And last but not least, I just realized I skipped that on the summary slide, so I apologize. So we're coming back to the detail on it. The restructuring pricing terms to minimize or eliminate PBM gameplay. Around this one, it's really around the spreadsheet. I always hear the term the spreadsheet. And since I was at a consulting firm 15 years ago, it literally hasn't changed. It's the same linear math, no real credit for clinical management, not a look at what's happening on prior authorization criteria, not looking at, when adherence rates are 110%, because that means there's wastage happening with auto refill programs. These are all the things that are not looked at. But we're going to tackle one that you can actually get at with your PBM consultant when you're having the conversation. If you are doing a per brand claim guarantee, this is the ultimate playground for PBMs to mess with the optics. And I have had many bids in my tenure where I quote per brand and I'm way behind. And then I give a per RX and oh my gosh, I am right on track or ahead. So what does that tell you? That tells you that these exclusions are not being evaluated or looked at as closely as they should, or they're just not understood. So that's through the defense of the consultant community. You can't keep up because there's always another game coming in there. So looking at a per RX, again, if it's $1 per RX and you have 100 prescriptions, it's $100. It's that easy. So there's a way to level the playing field, get rid of the games, and you're able to look at your deal in a much more structured way. And you're also able to communicate to your management that this is what we're expecting in rebates. It isn't this, we're really not sure, because there's all these exclusions and definitions. So again, really key in your contract, get a measurable metric for rebates and how they are paid from a minimum basis. And again, just because you have a minimum, you should still secure that you want 100% of all pharma revenue coming back to you, even outside of your minimum guarantee. So what legislative changes are happening to support and kind of validate what I'm talking about in these 5 things you can do in a deal? Consolidation Appropriations Act, basically on December 27th, employers had to file, not employers, but they were supposed to file, but sometimes PBMs filed for them, information related to the transactions that occur between a PBM and an employer. And the Department of Labor has been very clear that this is going to be like 401k all over again. They are going to be looking at the fees that are paid to PBMs through spread, through rebate retention, through administrative fees, through clinical fees. It's supposed to be all direct and indirect revenue. The PBM has to disclose that in a file that has already been uploaded to the HIO system through CMS or the federal government, and they're looking at that. Now, I will tell you, most of employers on this call hit the easy button and allowed their PBM to aggregate all that data with all their other clients and submit it, and you never looked at it. You missed a huge opportunity. We actually told our clients, we're not submitting for you. We want you to see there's no spread. There's no rebate retention. And until anybody has done the due diligence as a fiduciary to your plan, look at the information, demand that you see the individual report related to CAA, and don't settle for the aggregate filing that the PBMs make it easy for you, because trust me, you're not getting the visibility into what you need to see. The good news is for employers, this is what you should be demanding of your PBM through the Consolidated Act, that they must submit all direct and indirect fees paid or retained by the PBM. So if you're scratching your head saying, well, I don't know, I think they're keeping spread, but I'm not sure, the data's right there. You just haven't seen it or asked for it. Submit all rebate revenue as outlined in the CAA. Again, this is any owned rebate or aggregator fees. They're not exactly sure how that's going to play out in the ultimate submission as we go into 2022, which is due in June. We're going to get some clarity from the government on how those fees may be rolled up into that. And then again, remember, brokers and consultants are also a part of this Section 202 of CAA. They have to report their fees. We all got to look in the mirror here, people, and say, this is what we are adding to the cost of an employer benefit. Whether you are a PBM, a mail service provider, an aggregator, a broker or consultant, we all got to come clean and show the dollars. And they're all out there now with CAA. But I'd venture to say most employers have not taken the time to look at it, and you have to, because the Department of Labor and other organizations, they're going to come and make sure that you're being a good fiduciary of the plan, and that you're not just raising payroll contributions every year because there's lots of fees going out to your PBM or other parties. The other great validation is around state regulations. 45 states passed PBM regulations. I'm actually testifying tomorrow for another state regulation. And in this case, they're kind of all over the board. It can be around spread. It can be around there's some retail components around audits and how many are allowed to happen there. Licensure, which kind of would surprise you, but there actually are PBMs out there that are not licensed in every state they need to be. And that's an issue as well. So again, these are the kind of the cleanup things that are happening. The ones that I'm really excited about is, I can finally say I have some validation with NADAC. 3 states have rolled out a concept that NADAC were there defining their reimbursement minimum standard in their state. Tennessee and West Virginia in particular, again, just in the last 2 years, both said retail pharmacies have to be paid at least a minimum of X. You will notice that is not an AWP discount. That is not a WAC discount. It is a NADAC discount, because everyone knows it's the closest to the cost to fill for a pharmacy, and that dispensing fee is essentially letting you know what the profit is. And what does that do? That lets you as a consumer know where you want to go. Because if somebody else charges $8 on top of NADAC versus 10, you can save $2. It's that simple. It's not like today where you're really not sure where to go because the prices change because of all the manipulation I mentioned earlier. So again, we're getting validated on NADAC. You're going to see more of it, and it's only going to get bigger. Yeah, this is our sales spiel. I've officially left the sales team, so I will do this on their benefit. But obviously, with CapRx, everything that you see here as those 5 fundamentals are core in our contracts with you as a client. But more than that, we hold ourselves accountable, meaning I am not allowed to make spread on retail because I've made it impossible in my provider contracts to do it. So we've made sure that we will always be kept honest on these components. But to be totally fair, the market is moving in such a quick way, by evidence with the state things I mentioned earlier, that most PBMs are not even 20% of where they need to be when this all comes hitting. And CapRx is. We've been doing it for 4 years, very comfortable in this space. And last I wanted to leave you with, because of this model, because you can present price to people, our clients are elated. We have an NPS of 96. The market's around 15, some are in the 30s. So doing very well there. Our member NPS last year was 67. You may say, well, that doesn't sound great. NPS in PBM world is about 6. So we're doing great there. And actually after January, we hit 88. So that's considered world-class in terms of member NPS. So, providing the truth to people and clients actually creates a good relationship. Who knew, right? So it works for everyone at the end of the day. I want to thank you for your time and humoring me for this very quick 26 minutes that I did it. And I want to leave some time for questions. What do we got and where do I go here? Don't know if we have any chats. I don't see anything yet. Hannah, do you have anything on your side?
Nope, no questions yet. If you have any questions, you can submit with the Q&A feature at the bottom of Zoom.
I know you're all just speechless, right? All right. Well, I'm bummed I didn't get any questions because that's what keeps my day interesting. Oh, looks like we got some here. We got here. Hannah, for some reason, I can't read what's in the Q&A. Are you able to see it?
Yeah.
Okay.
Can you talk a little bit more about the state level NADAC guarantees?
Yeah, so it's a little bit challenging to know exactly if there's going to be ERISA impacts there because of the Rutledge case. There's some views that these are enforceable on ERISA or self-funded plans, but for sure on insured business, they must meet that minimum reimbursement standard to every pharmacy. So in the case of, let me see if I can get this to go back. Oh, no, well, now I can't. In the case of, I can't remember which state it was, I think Tennessee is 1198 or something like that. Every pharmacy has to be paid that minimum. Now, the way PBMs are dealing with it in general is they are adjusting their MAC list so it's equivalent to that standard. What I don't know is that on average? Is it, how are they doing it? In our case, because we are NADAC based, every claim will adjudicate at NADAC plus whatever that minimum dispensing fee is for that for the pharmacies. Looks like we got another one here. Does CAA require share of rebates to be reported for all commercial business? When did that go into effect? Yes, so CAA requires that any rebates retained by the PBM is reported in the submission, and that was all filed on December 27th. There was an extension to the 31st of January, but that should all be in now. Again, as I said, a lot of folks missed it because their PBM said, oh, we'll take care of this for you in our bulk submission, and you didn't see it. So again, I would suggest that you can still have them do that, but request your individual report so you can see exactly where the dollars are flowing. Got another one here, if I can scroll. Okay. Can you speak to the role of brokers in the RFP and PBM selection process? I mean, do you have an hour? Yeah, so I've been one myself. So they're a key part of the process, not just within PBM, but all of healthcare, obviously. And, you know, it varies. There's the whole gamut, just like there are in PBMs, there's a whole gamut of consulting houses from large firms to mid-sized to boutique is how I would kind of characterize it. You have those that are purely pharmacy and that's their whole line of business, or they're the larger firms where they have a larger health and welfare practice and pharmacy is one component of that. What I can tell you is that at the end of the day, every broker and consultant out there, I believe, is trying to save their client money. And it's really a conversation of let's think differently. If you're still plugging in the same numbers into the same spreadsheet for even 10 years, you gotta change. You gotta look at something different, because if you don't, your competitors are starting to, because there are firms that are getting a little more interested in this space and looking at alternative models. So I don't know if I'm answering the question, but again, intentions are great, but old patterns and old habits are hard to change. Can you, okay, that was another one. Let's see what we got here. Do you have specific recommendations for writing RFPs for transparent PBM? I do, and that's something you could write me after the meeting on. Certainly would be willing to give you some thoughts around that on the RFP side, how you structure the RFP. A lot of times I'll see, we want pass through, but you have to have guarantees in every channel. I'm like, well, that doesn't make sense. Because if you're pass through, you're pass through. Underwriting doesn't allow you to do component guarantees when you're truly pass through. Like that's kind of the nonsensical stuff that I could certainly walk through with you, and where we see conflicts in terms of we want transparent, but we really don't. So that's something I can certainly share. How is CapRx, PDTs? Was that PDEs, or I don't know what a PDT is. So I'm going to skip. I've been around a long time. I don't know what a PDT is. So sorry about that. To what extent should employers dig into PBM GPO arrangements? Is a GPO just another middleman feeding at the trough with the PBM sharing profits? You're funny. I mean, it's one of these things where it's very hard as a mid-market PBM to get competitive negotiations with pharma. And, you know, if you're on here from pharma, with all due respect, you've seen the mid-market all collapse into some GPO arrangements. I don't know any that are really doing it all exclusively on their own anymore, when they used to for many years. So unfortunately, it's kind of become a necessity of survival that in order to obtain the rebate levels you need to secure business, you are somewhat forced into some of these GPO arrangements. I don't know if it's something people don't necessarily love to do, but it's a necessity at this point. What else do we have? What do you see happening with PAP programs, and what should plan sponsors be aware of? I know I'm over time. If you want to stay, there's still almost 70 of you. So we'll keep going here for a little bit if you want. So patient assistance program, what's happening with them? So I will tell you, as a pharmacist, for those that decided to carve these drugs out and no longer cover specialty for their employers and leverage patient assistance programs, I don't know if that was really the best long-term strategy. Why? We know that it would eventually be cut off because those programs are not designed for people making $120,000 a year. They're designed for people that are indigent, don't have access, or underinsured. And I don't know why people are surprised we're seeing these programs be canceled or narrow. Well, it's because they're being overused. The math doesn't work out, right? So you're going to continue to see the PAP programs diminish, the criteria becoming more stringent, and honestly, the game is up. Employers are going to have to pay for your specialty drugs. That's what's coming. But you know, these programs were not designed for what exactly was occurring to be in the first place, and now we're seeing the result of that. All right. I got a question on, where is it? I'm scrolling the wrong way, I apologize. What are your thoughts on FTC and congressional investigations of PBMs? I mean, are these inquiries likely to drive any meaningful change? It's not like the first inquiry, right? So I kind of hold my breath until I see what's going to be done. And I guess I really don't. I don't wait or think that any of those moves, whether it's the FTC or the state, is what forces change. I do believe employers force change, and they can force things to be done in a much more meaningful and practical way than waiting for legislative or regulatory entities to do it. So my hope is, yeah, it's there. It could be interesting, but I think that the momentum among payers for a change in the space far outweighs and can be a much faster pace than a regulatory one. Are there drugs that do not have a NADAC, for example, when they are new to market? If so, how do you handle these? So by the time a pharmacy purchases a drug, they get it on the shelves, the NADAC's reported. So we don't have the new to market problem on the NADAC. You have about 1.5% of dispensed drugs that do not have a NADAC. Those are primarily made up of like vaccines as well as like in-store products. So if you're like a retailer and you have your own diabetes monitor, they don't report that to NADAC because nobody else has it. But in general, you're in pretty good shape there on NADAC for drugs. And I think, what do you think is the biggest threat? What do you think the biggest threat is to the PBM space? The biggest threat, I think it would be in terms of as I said in the beginning, PBMs are a necessary part of healthcare, and honestly have been the most technologically advanced part for many years. Now I think most PBMs are kind of falling behind because they're working on very old systems that cause a lot of manual work and overhead. For me, I think the biggest threat is not really, I think people will tell you, a single payer. It's more the fact that this consolidation continues to happen and vertical integration. If that is continued to allow to happen, there's going to be no incentive in the market for innovation. And all we're going to see is more and more consolidation and fewer phone calls like this where you're exposed to the truth. Got a few more here, it looks like. Oops, that's not letting me scroll. How is CapRx looking at prior authorization and clinical cost? Right, so this is, again, as a pharmacist, is a big deal to me. And I'll take these off, my eyes are hurting. From a PA standpoint, you should never be proud of your denial rate, right? That's not something you want to tout. But you should also not have an obnoxious acceptance rate. And most PBMs run in the high 80s to mid 90s in most categories. And when you look at that criteria, which again, most brokers and consultants don't go to that level, and in their defense, they don't have the clinical resources to do it. But when you look at it, you'll see a managed care plan or a PBM like ours, we're in the 50s and 60s for approval rates. And the reason that is we require documentation, and actually having a pharmacist review every PA, but you're probably like, well, isn't that what happens? Nope. All the PAs are reviewed by techs, and only denials are reviewed by pharmacists in most PBMs. So you have this opportunity where over approvals can happen. And I think, as far as a fundamental philosophy, I believe every PA should be reviewed by a pharmacist, and the criteria should actually require documentation and not attestation. Those are kind of my two rules on PA. Well, I think we are way over. I appreciate the 62 of you hanging on with me. Either you are eating lunch and not paying attention, or you're completely compelled. But either way, I want to thank you for taking time with us today. You'll see our information here on the slide. You can reach out to me directly, LinkedIn or email, and I will get you in touch with the right people. But we would love to do business with like-minded folks and change this industry. As I said, it's going to come from folks like you and us. Regulators might catch up. That'll be great. But I think the time is now, and we have the tools to do it, and excited to see where we can go together. Thank you.